many people actually are doing pediatric cataract. So all of you are doing pediatric cataracts? Perfect. So whenever I need more than 2 hands to count, I feel happy. So good. So we got 20 people. When you count with 2 hands, it's 10 only. So it's more than that, means more than 10 is good enough. Okay, so we'll be presenting to you in a nutshell what is pediatric cataract and how you go about it. And this is a course which we've been running in the Chicago, in all these American academies, for which people pay $100 each to come, and it's all free for you. So I won't do more talking. These are my seniors and registrars. They are all trained, well-trained pediatric surgeons. They're doing a great job. Okay, so just checking it up. So you can have your questions. We can have all the queries at the end. We'll have around 15-20 minutes. And even after that, you can have the mail IDs of these people, and you can talk and interact and check out whenever you want, whatever you want. We'll try to break it into simple steps and like to give you, I'll finish it off with the IOL power calculation because that's a question which it's in everybody's mind. So we did some studies at the center in which we followed 3-4 years down after surgeries, and we realized what is happening in our Indian eyes. Because Western eyes, Indian eyes, they're a different ballgame altogether. So, like, for example, the Hans and Prost used to give 20% undercorrection at the age of 2 years, which was huge. We tried about 30 years back when we started doing this. And most of the patients were still hyperopic when we left them when they were over 18, 19 years of age. So that is not going to work very well in Indian setup. So we will discuss all those things. And I think we'll share, anybody who wants to share something at the end, they're most welcome. So we just got 1 minute now. So you check those ones also? Fine. So I have Aishwarya. She's a senior resident with us, a great surgeon. She's a left-handed surgeon, so all these left-handed people can ask her how to manage the instrument. It's not the same. When I go to play golf, and if I have a wrong club in my hand of the opposite side, you just can't do a shot. So you have to be very careful of what you do. Diksha just finished her registrarship. She's going to start her practice in Mumbai, and she's one of the very good surgeons, fine surgeons for pediatric. And we have got new kid on the block, Majumdar. He's basically, Ayush is just joined, but he'll be covering up the preoperative evaluation in these patients. I think every step is important. Surgery is the least important, but how to do it properly is what you should see. But the rehabilitation, the pre-op workup, and more important, talking to the parents, that's the most important. So I think I'll start it now, time, okay? And I don't need an introduction, so don't introduce. Okay, so we used to get about 2 patients in a month. Now we get about 18 in a week, 15 to 18 patients we get in a week. Why? Because one, it's a referral center. And second, most of the private setups don't have the capability of GA, and they don't want to follow the patient. These patients actually will stick with you for next at least 30, 40 years. And that's why if you do it properly, do it. If you don't know how to do it, please pass it on to somebody who can manage it well. So it's basically institution-based. You need a good, safe anesthesia. But if you see the epidemiology, it is about 1 to 15 in 10,000. So the unit they take is 10,000 live births. How many are there is how they calculate. So different parts of the world have different setups. But if you see, okay, so when the parents bring the children and you tell them you got a cataract, the first thing is cataract in a small child? Are you nuts? Is it not a senile thing? The answer is no, and its number is rising up. Parents are to be taught about it because the child can't understand anything, and all these things about glasses, compliance. I mean, you just can't do a surgery in a patient in which they're not going to wear the glasses because we're undercorrecting this patient, so they might have a mild to moderate hyperopia left, for which the glasses have to be worn till they outgrow those glasses. They'll need the glasses forever, actually, after that. You're putting bifocal glasses for them, and eventually, if you can put a multifocal lenses later on when the child's growth stops, you can do them, but till that time, you have to make sure that the patient wear the glasses and have vision rather than going blind. Unilateral cases needs patching, but then again, parents have to be taught properly how to handle this properly. If they don't do the patching, I think everything's going to fall flat. All the siblings have to be evaluated. So in my setup, in RP center, if the parent comes with the child, we dilate the parent's eyes also. Both the mother, father will come We don't want the uncles and nephews and neighbors to bring the child. We want the parents, actual, real, biological parents. And you put one drop of tropamide and just do a distant direct, you can actually see. So many times we picked up mother having as a carrier, and it becomes a Hans-Noran syndrome. But you have to look for it, right? And this is not a one-window surgery like an adult cataract or a LASIK surgery. Patient pays and gets surgery, goes, never comes back. Here the case starts after the surgery. So once you've done a surgery, follow-up has to be done, suture removal has to be done. So every time the patient comes, you have to give it diligent examination on this one. So basically the cataract forms very early in life without even the female realizing that she's pregnant. The lens starts forming. So that's a placode. I'm not going into the details of the genetics, but by 45 days, the lens is almost ready. So if you see the spectrum, everywhere there's the rise in USA, earlier they thought they were less patient, but now with the migratory population there, their number is also whooping going up. So they all are looking for pediatric cataract surgeons. So if you're ready for it, I think I'll wish you all the best. We did a study at the center in which we took the data of about 2,000 patients coming to our center. We realized that the majority of them were actually developmental cataracts, about 45%. Traumatic was very high. We're not dealing with the traumatic today because we're talking about the non-traumatic cataracts only today. And the last group here, 6% is the one visual excess opacification. That means if you haven't done the surgery properly, you might still have complication. You might need a resurgery. So you've got to be careful about that. So with that in mind, if one child is blind, there has to be a relative who handles the child. So there are two people who are not working for the GDP of the country. So they're basically not helping the economical cause. So you have to operate. A stitch in time will save 9 is very apt for this one. With this one, if the patient comes to us, how will you go and do a preoperative workup? Over to Arush.
Can I have my slides, please?
Can I have the other? Yeah, please. There you are.
Yeah. So let's talk about preoperative evaluation in cases of pediatric cataract. As we know, a comprehensive preoperative workup is the cornerstone for achieving optimal postoperative outcomes. So approaching a child presenting to us with a cataract, first obviously we have to start with a detailed history taking, followed by assessment of the presenting visual acuity. Then we move on to the systemic evaluation of the kid, look at the ocular examination, and finally do a biometry and required ancillary investigations. So when the parents bring us a child with a cataract, some of the chief complaints that they can bring it with is the presence of a white reflex, the complaint of closing eyelids or squeezing the eyelids in the presence of bright light, bringing objects closer to the eyes for viewing them, abnormal eye movements, or the complaint of rubbing of their eyes. So when the parents bring their child with these chief complaints, we have to look at several factors. First of all, the educational status of the parents and how reliable is the history actually. Then we have to look at the detailed sequence of events of what happened and how, and any intervention which was sought previously. Then we have to ask for the significant family history and draw a detailed pedigree assessment to see if there is any familial nature. Then we have to take a detailed birth history, starting from the antenatal history, that is if the mother had any history of fever or rash during pregnancy, if there was any drug or radiation exposure, then going on to the birth events, and finally, postnatally, the immunization status. Then we ask for any food or drug allergy, and then we move on. If a patient's chief complaint is the presence of a white reflex, we have to rule out other major differentials as well. So looking at the anatomical location of the leukocoria, we can have things anterior to the lens, which include a corneal opacity or Peters anomaly. Then we can have lenticular opacities themselves. And finally, posterior segment anomalies, like a retinal detachment, a vitreous hemorrhage, Coats disease, toxocara, or persistent fetal vasculature. Once we have looked at the history, now we move on to assess the visual acuity. And one of the first things that we have to look for is the fixation status of the child. So when we are assessing the fixation, we have to notice where the light reflex is when we shine a torch from a distance. And if it is directly at the center of the pupil, that is central, it implies that there is foveal fixation, which signifies that a good visual outcome can be hoped for.
Magnified, I think. Okay. Yeah.
So a central fixation implying a foveal fixation is a good predictor of good visual outcome. Then we move on to see if the fixation is steady or not, which implies that there is no nystagmus, and then whether it is maintained on a cover-uncover test, which again, the absence of a nystagmus or strabismus implies better outcomes. Now we go on to various modalities of visual acuity assessment. Starting from pre-verbal children, that is infants, we have various techniques available with us, which include Teller's acuity chart, which is square wave gratings and based on the preferential looking principle. Then we have the optokinetic nystagmus drum, which has again gratings, and we see whether the child is able to follow, how fine the gratings the children is able to follow. And finally we have the Catford drum, which has dots of varying sizes, and again we look at the smallest dot which a child is able to follow. In the age group of 1 to 2 years, we have the Cardiff's visual acuity test, which is based on vanishing optotypes. Then we have Worth's ivory ball test, in which ivory colored balls of various sizes are rolled across the floor, and we see the smallest size of the ball that the child is able to follow. And finally we have the Steicar test, that is the screening test for young children and retards. Then in the age group of 2 to 3 years, we have the miniature toy test, the coin test, and the Lee symbols. Again, we are looking at the smallest size of the object that the child is able to follow. In the age group of 3 to 5 years of age, we have the Allen's picture card test and Lipman's HOTV test. And finally, in school-going age of more than 5 years, we can have the same test that we use for adults, namely the Snellen's chart, the tumbling E chart, or Landau's broken ring test. Once we have had some estimation of the presenting visual acuity, we move forward to examining a child, which can be really difficult. And so we have to ensure that the child is positioned comfortably. And for any child, the most comfortable position is the mother's lap or the shoulder. So we ask the mother to take the child on her shoulder and then turn towards us. And then we can start assessing a gross assessment of any abnormal facies or any syndromic facies, which we might be able to identify. Then before a dilated assessment, we have to look for the pupillary response. A brisk and equal response in both the eyes suggests better outcomes. Then we do a distant direct examination to look at the anterior segment structures, starting from the cornea to look at the presence of any corneal opacity, then looking at the anterior chamber depth, presence of any peripheral anterior synechia or posterior synechia. And finally, we dilate the pupil to look for the presence of the morphology of the cataract that we are looking at and to see how much the pupil dilates. Then we move on to the systemic evaluation of the kid, which is of utmost importance, and this is guided by our history and examination that we have undertaken. So like if a mother gives the history of a presence of any fever or rash during pregnancy, we can suspect any of the torch infections, and the torch profile needs to be sent. If the child has history of seizures in the neonatal period or suggestion of a gross developmental delay, a neurology opinion has to be sought. If during our examination we found a non-dilating pupil or posterior synechia or any such feature which suggests a uveitic cataract, then we have to assess for a rheumatology opinion. If the patient has features of a Marfan syndrome or a rubella cataract, then a 2D echo has to take place. And finally, if the morphology of the cataract is something like an oil droplet which we find in galactosemia, the fasting blood sugars and urine for reducing substance has to be sent. Now there are various syndromes which can be associated with a congenital or developmental cataract. Some of the syndromes which we have come across at our center, which is a JAG1 mutation, in which the associated features are broad nasal bridge and an epicanthus palpebralis, butterfly-shaped vertebrae, lamellar cataract with riders as shown in this image, and a posterior embryotoxon. And these have associated limbal stem cell deficiency. So on impression cytology, we found goblet cells on the cornea. Then Larsen syndrome, which is a collagen 7 synthesis defect, which presents with developmental cataract, patchy alopecia, syndactyly, polydactyly, and low set ears, along with a limping gait as seen in this video. Along with this, on fundus evaluation, there is diffuse chorioretinal degeneration. Fetal valproate syndrome usually presents with a history of valproate intake by the mother during the antenatal period. It has a typical facies of broad forehead with a telecanthus and epicanthal folds and is associated with a total white globular sort of cataract. On fundus evaluation, we can have a normal disc but a diffuse chorioretinal degeneration. Then this was a case of Sickle syndrome, which presented with a microcephalic primordial dwarfism and triangular facies. This is an autosomal recessive condition which presents with bilateral developmental cataracts. Now, once we have looked at the systemic features and we have done a visual acuity assessment along with an ocular examination, we move forward to our operative planning. And again, the cornerstone of an operative planning is the biometry. Now, axial length assessment in these children can be really challenging, and more so because there is a high rapid growth during the initial age. So immersion A scan, although theoretically is more accurate, since it precludes the indentation of the central cornea as seen in contact scans. However, since we cannot ensure proper fixation during an immersion A scan, this is not so much useful in children. So most commonly we do a contact scan method. And when we are doing a contact method, maximum AC depth should be taken so that we have some idea of it going through the fovea. And an axial length of more than 17 mm is preferable for IOL implantation. From axial length, next we go on to keratometry, which is usually done under general anesthesia during our examination under anesthesia using handheld keratometers. However, in children, older children who might cooperate, optical biometry is still the gold standard. Then, another predictor of postoperative outcomes is the presenting intraocular pressure, especially more so because pediatric cataract is associated with pre as well as post-op glaucoma. So during an examination under anesthesia, Perkins tonometer to assess the intraocular pressure is of utmost importance. And any factor which predicts the presence of glaucoma, like rubella cataract, uveitic cataract, or a post-traumatic cataract, must be especially watched out for. Next, we move on to ultrasound biomicroscopy, which is an extremely useful tool. It is a non-invasive modality working at high frequencies of 35 to 50 megahertz, thus having lesser penetration. And this can help us in the preoperative assessment of sulcus, such as when is required for a secondary IOL placement, then the lens thickness and the morphology of the cataract itself, which can help us in planning the surgical steps, the bag diameter, and the presence of certain features like a posterior polar cataract, a pre-existing posterior capsular defect, or the presence of a persistent fetal vasculature. I'll be showing some images of ultrasound biomicroscopy. For example, this first image is a typical zonular cataract with a central clear zone. Another one in which the cataract is predominantly central with a peripherally clear zone. This is one which has a pre-existing anterior capsular rupture, and we can see the cortical matter protruding into the anterior chamber. This is a case of microsphere phakia in which the lens is almost coming into the anterior chamber. And finally, we have one subluxated lens with a posterior lenticonus, as can be seen in this image. Now comes the most important part, which I'll be just touching upon, that is the IOL power estimation. Now we know IOL power prediction is very uncertain in children, and we have conflicting literature published. One thing we can all agree on is IOL is to be implanted in only those eyes which have adequate size, that is axial length more than 17 mm and wide to wide of more than 9 mm. Now, like sir just said, the predicting the IOL power is very difficult, and these various formulae have been described, which sir will be covering in details. So that is all in preoperative assessment. Next, we move on to the surgical steps.
Thank you, Ayush. Can we have the phone switched off, please? Excuse me, sir, red shirt. आपका phone से disturb हो रहा है. Phone बाहर जाके ले लीजिए. बाहर भी ठंडा है. Okay, so once you decided which patient to operate, right? So the cataract which is significant, I think she's also going to touch upon that. Now we're going to show you how to pick up the patients, how to do it, when to do it, and which ones not to do. And the most important thing here is that till you've done a EUA in a small child, you're not sure what the child is showing you, right? There could be a flat anterior chamber. There could be an anterior capsule bulge which has gone backwards. So if you're smart enough to pick up these things in which you can make out that the lens is going behind the iris, that is an indirect sign that its convexity has lost because it's opened at the back. So now we're doing a study in which we found out that all these patients in which the anterior capsule curvature is lost are actually having posterior capsular defects. So I think she's going to show you a few things on that. And are we ready with the surgicals? Can you just adjust the slide for her? Any queries you have, please write it down and feel free. We can answer whenever we have ample time for that.
Is it fine? Can you please adjust?
Yeah, that's better. That's better. Okay.
Okay.
Diksha, all yours,
Good
please.
afternoon, everyone. Thank you, sir, for this opportunity. I'll be discussing the surgical management of pediatric cataract. So the success of pediatric cataract surgery depends upon the meticulous surgery, a proper follow-up, and a compliance to glasses and occlusion. And for a proper and meticulous surgery, a good anesthesia team is mandatory. So the basic concept of the surgery is to clear the central optical area And not just that, we also have to remove the scaffold for formation of visual axis of pacification. And along with that, the support for IOL has to be maintained, least traumatic, minimal manipulation, so that we can have better visual outcomes. Now is when to operate. So for children, doing a cataract surgery is not just a simple thing. The child loses his accommodation. He is bound to glasses for lifelong. So we should operate only when it's needed. So the cataracts which are lesser than 3 mm can be managed with refraction alone. And if we can ensure that the light is entering the eye in an undilated pupil, we should always put the child on glasses and follow. Whereas if the central cataract is larger than 3 millimeters, that is the pupil is being occluded, undilated pupil is being occluded, we should go ahead for surgery. The cataracts closer to the posterior pole, again because they are closer to the nodal point, cause more visual problems and hence should be operated. When retinal details are not visible for further evaluation, that becomes another indication for surgery. In cases with abnormal movement, again when fixation has not developed, we should go ahead early. And if nystagmus is present, the child is less likely to get better vision better than 6/12, again because foveal fixation time is less. Next is when to operate. Frankly speaking, earlier is the best, but for very young children, there are higher risks of general anesthesia, and at the same time, there's a higher risk of sometimes glaucoma if the child are operated at the age less than 1 month. However, we still do for ROP children, even for 10 to 15 days of age, we still do. But if there are no other such indications, that the surgery can easily be delayed till 4 to 6 weeks of life. Earlier for unilateral cataracts because of higher risk of amblyopia, while bilateral cataracts, 6 to 8 weeks is a good time. And for symmetrical cataract, second eye should be done within 1 week of the first eye. And in cases where there is difficult GA or systemically unstable patients, both the eyes can be operated in the same sitting as well. Now, why are we having a separate discussion for pediatric cataract? Because the surgery itself has many challenges. The first is the anterior chamber instability. Others are increased capsular elasticity, decreased scleral rigidity, again because of thin sclera, the higher tendency of intraocular inflammation and visual axis opacification. Well, the aspiration of nucleus is very simple. There are other things to be handled which need more care. The very first thing is head positioning. If the head is not positioned well, we cannot aim to have a smooth surgery. So the head, before we put in the drape, we have to ensure that the head is parallel, the exposure is good. We need a head ring under the head and a shoulder roll to ensure that the exposure is good. So here we can see that this is the appropriate head ring for this child, and after the child is intubated, the neck support, we place the head ring. This is now followed by placement of shoulder roll under the shoulders to ensure a good exposure to the eye. So now the shoulder roll will go under the shoulders so that the neck is slightly extended and we have a better exposure. Besides that, we should use a proper speculum of appropriate size. If you are using too small or too large a speculum, there will be pooling of fluid, and that will decrease your visibility. So once everything is done, we now start with the surgery. The first step is incisions. 3 incisions is what we usually start with. Side port should be 180 degrees apart, and first incision should be made with non-dominant hand. And if chamber gets shallow, you should refill with OVD before starting for the next incision. Otherwise, you can have long and irregular incisions. Next step is staining of anterior capsule. Adrenaline can be used for adequate pupillary dilatation, and trypan blue 0.06% is used under air to stain the anterior capsule. And after staining, the entire dye is washed out. And you can even press the posterior lip of incision so that the dye comes out of those, and the incisions can also be stained. The next important step is anterior continuous curvilinear capsular axis. Now, pediatric anterior capsule is more elastic, plus the vitreous is firm, and hence the structure of the anterior capsule is this. Now, once you start rexing this thing, there's a high risk of this to extend, of the anterior capsular axis to extend. So we need to flatten the anterior capsule by inserting a heavy OVD, for example, Helon GV, so that the convex anterior surface can be flattened, so that now we can have a smooth surface and a controlled rexis can be done. We can use image-guided systems, or we can put marks on cornea to ensure the size of around 5 millimeters. And we have seen in clinical practice that this most common morphology of cataract, that is zonular cataract, the central ring is usually around 4.5 to 5 mm. So even if we do not have such systems, we can use the central ring as an approximate guide to the size of our anterior axis. So again, the same thing, manual CCC is a gold standard. And for cases when we are planning that we are leaving the child aphakic, we can even use vitrectomy for anterior capsulotomy. And in complicated cases, for example, persistent fetal vasculature, where we have a vascularized anterior capsule, the vessels may need to be diathermized or coagulated with a fugose blade so that we can have an opening in the anterior capsule. The next procedure is hydrodissection and hydrodelineation. Now, these maneuvers should be done with viscoelastic still in the eye, because the vitreous upthrust is too high that if you do it after removing viscoelastic, you will not get a hydrocleavage plane. And this is then followed by bimanual cortex aspiration. Now, after the cortex has been aspirated, the next important step is posterior continuous curvilinear capsular exis. So OVD is injected into the eye, into the interior chamber, and not in the bag. We do not want the PC to become excessively bowed towards the vitreous cavity. So we want the posterior capsule to be flat so that approximately 3 to 3.5 millimeter capsular exis can be done. And again, for sometimes we have PFV patients where we can have vascularized posterior capsule. In those cases, we may need to diathermize the membranes. So coming to the discussion for age limit for PCCC, till 5 to 6 years old, 6 years of age, PCCC with anterior vitrectomy is mandatory without any doubt. For older children, we can have personalized decision for each child. Again, it varies. It is not specific that if a child is 6 years and 2 months, we cannot do a PCCC. It's always a clinician's decision whether the child will. See, the indication is that it is not that if it's a 7-year-old child, if we do not do PCCC, he will not develop VO. He will develop VO. The only idea is that at this age, the child will be cooperative to sit on YAG and get a YAG capsulotomy done. So if the child is uncooperative, the child is having some developmental issues, in those cases, a PCCC with anterior vitrectomy should be done at any cost. Next we have is anterior vitrectomy. This is done to remove the scaffold, again to prevent the formation of VO. So 23 or 25 gauge vitrectomy is used. We use a high cut rate and low aspiration flow rate. We have to do the cutting bimanually around 1 millimeter beyond the margin of PCCC. And you can see with the cutter in the eye down mode, we go beyond the margin of PCCC and cut it all around. Again, after this, we change the hands and cut it similarly in the other direction. The end point is that the margins of the posterior capsule should curl and fall back. And next step is IOL insertion. The donut, this donut is filled with OVD, so that we have space, and the IOL is to be inserted under the anterior capsule. We should inject this as if there is no posterior capsule. If the support of anterior capsule is taken, the IOL goes in the right place. So the simple analogy that sir explains here is the landing plane. So if the direction is down, you'll have a crash landing. You will directly land into the vitreous and everything is gone. But if you direct it under the anterior capsule, it will have a smooth landing. You direct the leading haptic in, and the trailing haptic is then easily eased in, and the IOL is here in place in between the anterior and posterior capsular axis. The main wound is sutured with 10-0 monofilament nylon. Single suture is usually enough. For elder children, like after 7 or 8 years of age, we can leave this incision sutureless as well. The side ports, usually we need not suture. These can be hydrated, and in the end, the surgery ends with a subconjunctival injection of gentamicin, dexamethasone, and atropine. Now, besides that, there are certain new advancements that have currently come up at our center that we are using intraoperative OCT for OCT-guided pediatric cataract surgery. There are certain specific advantages. It allows us evaluation of cataractus lens as a whole. We can see the intralenticular changes and then alter our surgical decisions. Opacity, thickening, and duplication of posterior capsule can be better delineated. We can even delineate the Burgess space well, and it can also help us to look at the anatomy of the corneal wound. So this is one of the images where we can see that the IOL is placed well between anterior and posterior capsule. Another image showing a posterior capsule plaque, and it can be seen that the plaque is involving the whole posterior capsule. So this is another case where the clinical picture shows a PC plaque, but on OCT it can be seen that the entire thing is behind the posterior capsule, and posterior capsule is intact. So after rexing the posterior capsule with the forceps, the entire muck can be cleared off, and then we have a regular posterior capsule or PCCC, and IOL can be placed in the bag. Another case where the Berger space can be delineated in this shape as was shown. We have created a small nick and injected Helon in the Berger space. Now the concave configuration of the Berger space has now been converted into a convex morphology because of the Helon. So now we have a dome up PC similar to anterior capsule. And now we can create a small can be a technique of placing using bag in the. So we went ahead with anterior vitrectomy and placed the single piece IOL in the bag. Another indication is detecting the morphology of cataract. Now here in the uveum, we can see that the cortical fibers are very compact. And similarly, even in IOCT, we can see that lamellae are very dense. So these dense lamellae are usually very difficult to aspirate with IA. And we have noticed that we had to use phacoemulsification energy in such young eyes also in these specific morphologies. So these decisions can be made preoperatively with the help of IOCT, which helps to streamline the process and fasten the process of surgery. So that's it for the surgical management. There are further complicated cases are not being covered in this IC. The follow-up and post-operative care will be discussed by Dr. Aishwarya. Thank you.
Thank you, Diksha. So basically, she covered up how go about and how to. I think the most important thing is the placement of the patient, because once you got an LM inside, you're not supposed to shake the head. In the adult, you can ask the patient to look up, down, and you can move the head sidewise. Here, once the patient is fixed and covered, you're not supposed to even move the head, not even a chin up and down. So that's one point she mentioned, which is very important. So head position is very important, and I should be looking straight up inside. And these technologies, which we mentioned at the end, IOCTs and all those, if you have it, it's very good. If you don't have it, I think techniques is what we're discussing. Technologies you can always buy with a cost, right? There's a MasterCard for that. So please pick up the techniques, and if you have any queries, if you have any suggestion, we can talk about that. Technologies, like in the last video, there's certain cataract, even 2, 3, 4 months old kids, in which the lens takes long to aspirate. So lots of fluid goes in, the ring gets tumbled up and down. So if you've done a good UBM, if you find that there's a detachment of the cortical fibers from the capsule from all the side, and there's a ring, which she showed the ring sign, in those one, it's best to go 2.2 and go with the phaco handpiece. You don't need to have energy with a minimum, because the opening of the tip is more, so it'll just suck up the lens, and then you can do a bimanual later on. So it'll save you time, and endothelium cells will be protected more. Okay, so once you've done a surgery and everything's gone, at the end of the surgery, we give them an injection with we give an antibiotic, we give a cycloplegic. Atropine also is must in these patients, because next day we see the patients and we can do the refraction. Okay, so now over to you.
Good afternoon,
Aishwarya.
everyone. I'll be discussing about the post-operative care and management and rehabilitation after pediatric cataract surgery. Thank you, sir, for the opportunity. So, as we all know that pediatric cataract surgery has 3 main essential parts. First, the preoperative management, the intraoperative, and the postoperative. The postoperative medication is the first thing that comes to our mind once the surgery is over. And like any other adult cataract surgery, even in pediatric cataract surgeries, you basically give 3 topical medications. One is a tapering dose of steroids, which in our center is prednisolone acetate, which we start 6 times a day for the first week and gradually taper it over 6 weeks. Second is the cycloplegic. In adults, we use Tropac for maximum a week, but in children, we need to use hometropine or atropine, which are stronger cycloplegics, for a longer duration of time, because not only does it help in relieving the pain, it also helps in reducing the inflammation, which in turn reduces the chances of formation of a visual axis opacification. And third, like any surgery, we need to give a course of topical antibiotics, which in our case is 4th generation fluoroquinolone. Coming to follow-up, now in adults, you may see a patient once or twice after the cataract surgery and then it's done. But in children, you need to have a strict follow-up schedule, which in our case is day 1 post-op, 1 week, 1 month, and then 2 to 3 monthly for the first 6 months, and then 4 to 6 monthly for the next 3 years, following which it can be done annually. This was similar to the one that was followed in the IATS, or the infant aphakia treatment study, where they had a similar schedule for follow-up. Children need to be followed up lifelong, because the surgery done at 6 months or 1 year of age can have implications and consequences which may present decades later. Now, there are multiple challenges in the management, post-operative management. First, we need to educate and motivate the parents, because they have a myriad of emotions surrounding them. They may be panicking, they may be distressed, they may even feel guilty or angry regarding the child's diagnosis and the cataract surgery. So we need to alleviate their distress, explain to them that this is a holistic and a comprehensive approach from the doctors as well as the parents to help the child reach his maximum visual potential. On the first post-operative day, you look for a red reflex on a distant direct ophthalmoscope. Now, what a simple good glow on a DDO can tell you multiple things. First, that the media is clear, that you have done enough and sufficient media clearing lens aspiration. Second, if the glow is good, you'll be able to appreciate 3 lines: a line for ACCC, a line for PCCC, and a third line which shows the edge of the IOL. If you can see 3 circles, it very well tells you that your IOL is very well placed. It's not indenting either the anterior or the posterior capsule. There is no vitreous coming from the posterior capsule. The IOL is in the bag and it's not coming into the sulcus. Third, what a good glow tells you is an approximate amount of a refractive error that may be there. And hyperopia of 5 to 6 can be detected by the type of glow that is present. Fourth, the fact that the pupil is dilated tells you that the medication was put properly in the child's eye, and the parents and the nursing staff have put and complied with the medication. And last but not the least, the fact that the child is opening the eye to see the DDO means that the suture was very well buried and there are no loose ends to make sure that the child is having pain or any discomfort. Secondly, what we do here at our center is retinoscopy on day 1 in unilateral as well as bilateral cataracts, and patching of the other eye. So what we essentially do is we remove the patch from the eye that was operated on the next post-op morning, and we put it on the eye that was normal or having the better eye, the other eye. So what it does is it sensitizes the parents towards an increased compliance for glasses and patching. If you have given the glasses to the parents in the hospital itself, they'll be more adherent to the schedule that is given, and the fact that the glasses are important will be understood by them. Also, the fact that there are multiple children doing the same thing in the pediatric cubicle or the pediatric ward that you have encourages parents to follow each other's views and wear the glasses and strictly adhere to the compliance that is explained to them. So what we see here is the post-operative day 1 retinoscopy that has been done, and as was seen in pre-operative, the child is the most comfortable in the mother's lap, and there we do the post-operative retinoscopy. If the child has bilateral cataract, between the first and the second cataract surgery, we give glasses. The immediate glasses help in increasing the compliance. So what it does is we give plano in one eye and we give the retinoscopy in the other eye. It may not be exactly accurate, but it puts the thing into the parent's mind that glasses is must, and it must be a part of their normal daily routine. This is on the child on the left is a 4-month-old child with a plano in one and +8, +9 in another, and another child is a 4-year-old child with a plano in one and an executive bifocal in another. Post-operatively at 1 week, if we confirm the compliance. Now, how do you do that? When the child walks into the OPD or when the parent brings the child, if the child is wearing the glasses and has a patch on the child, this is a sure shot telltale sign that the child is compliant with the glasses as well as the occlusion. Another thing that you see at 1 week post-op is the fixation. We have seen in multiple of our cases that the child who had wandering fixation movements and was not fixing suddenly starts having a better fixation, a central fixation, and even if there was a preoperative squint, it starts reducing as early as first week post-operative because of the increase in the visual acuity. For older children, cardiac-for-tellers, relatively older children, cardiac-for-tellers can be done, and for older children, Snellen's visual acuity can be done. You need to re-explain the tapering of the steroids and the medication when the parents come to you. Post-operative, 4 to 6 weeks, you do an examination under EUA, anesthesia, and you remove the suture that you had put in the main incision, and you do a biometry repeat to see how much the axial length has grown, the keratometry has changed. You check the IOP, you do the refraction again, and you also see the fundus to see if there is no abnormal changes. It ideally must be done every 6 monthly or when you see an abnormal glow. And if there is a significant visual axis opacification in the same EUA, you should go ahead with membranectomy. The second part of the post-operative management is visual rehabilitation, which essentially has two arms. One, refractive correction, which mainly includes glasses and contact lens. And second, amblyopia management, which is basically occlusion therapy as far as gold standard is concerned. Now in glasses, it is especially important that the parents understand the importance of why children need to wear the glasses continuously, because we have undercorrected these children. These children are 6 months, 1 year, 2 years of age, and according to multiple formula, we have undercorrected the child up to +6, +7. And if they do not wear the glasses, they'll essentially go into, again, amblyopia, which is probably futile for operating the patient because the child is not wearing the glasses. It helps my case because I'm wearing glasses myself, so I can explain to the patient that it is necessary to wear it, although it becomes a problem in explaining and convincing the patients of refractive surgery. Going to sizing, this is an extra problem that is there in children which you do not inquire in adults. The large glasses can cause eyelashes to not open, and it may touch the eyelids. The child may not be able to open the eyes, so we need to ensure that the sizing is proper, and the rim sizing should also be proper, because if the child is lying down, the glasses may ride up, changing the back vertex distance and the retinoscopy itself. What we can do to manage this is wear glasses that have cable temples so that it can be snugly fit, and harnesses that are present overhead or behind the head so it can make the glasses stable on the child's head. Aphakic glasses are slightly more difficult because they have high power, around 20-25 diopters, causing all sorts of distortion. So specific glasses like lenticular glasses, we have power in the center, or aspheric lenticular glasses, which also combat the spherical aberrations, can help in reducing these distortions. There are also multi-drop glasses which have spherical central high power and a peripheral low power, which can reduce the distortion and help in cases with bilateral aphakia. In aphakic glasses, the frame should be small and the depth should be sufficient of the frame to allow these glasses to be put in those frames without pushing back on the eyelids. Contact lenses, there are 3 basic types of contact lenses: silicone, RGP or rigid gas permeable, and hydrogel lenses. The silicone lenses have the highest oxygen permeability and were followed in the IATS protocol. They give +2 diopter of overcorrection for children less than 2 years and bifocals with near eye in children more than 2 years. RGP lenses are used when silicone contact lenses power are not available, or in corneas that are small like microcorneas or cornea less than 9 mm. Hydrogel lenses can be used in older children because they are easily broken and easily damaged, so they are avoided in younger children. The second arm of the visual rehabilitation is amblyopia. Now, a preoperative stimulus deprivation and a postoperative ametropia or an anisometropia is the cause of amblyopia in pediatric cataract surgery. So 2 things you can do to manage it. One, provide a clear retinal image, which you're doing by doing the cataract surgery itself. And second is by correcting the ocular dominance. Now, occlusion therapy is the gold standard for amblyopia management, which can be either partial or total, and full-time or part-time. With increasing evolution of how amblyopia is responding to occlusion therapy, we are shifting from a full-time to a part-time occlusion, because even the ATS, the amblyopia treatment studies have shown that even in dense amblyopia, 6 hours is equivalent to full day patching, and 2 hours is equivalent to 6 hours in severe amblyopia and moderate amblyopia respectively. Another thing what part-time patching does is it increases the compliance of the parents, because they would not like to put the patch on the child for the entire day, but if you tell them 6 hours, they'll be more compliant to it. And thirdly, it also allows for the development of binocular ocular dominance columns, because as there is a time during the day when both the eyes are open, so those neuroplasticity can help develop binocularity if the surgery has been done before the fixation and the binocularity develop. Now, there are multiple objective methods called occlusion dose monitors, where there are miniature skin electrodes attached to the patch, which can actually tell you how much time the occlusion patch was put. There is another way of thermal sensing, where there are thermistors which are there in the patch, which can tell you how much the contact was there of the skin with the patch. So we can check how much the occlusion was done compared to what was actually prescribed. The occlusion has to be done such that there is no light coming into the eye that is normal or better. If the eye, you see the lower image, and if the light is going into the better eye, the child will try to look through that eye and the entire process will become futile. The IATS did 1 hour per day till 8 months of age, and after which they did either full waking hours right eye and the alternate day left eye, or full waking hours divided into half for the right eye and half for the left eye. If for 3 months there is no response to occlusion treatment, it is a failure of occlusion, which can be either the first and the most common reason being poor compliance of the parents, second, a later age at which it was started, third, a very dense amblyopia, and fourth, a cataract surgery that was congenitally present, leading to a very severe loss of vision. In recent times, an active vision therapy has also been used along with an occlusion therapy as an adjunct, as it helps in stimulating the neuromodulatory pathways involving dopamine, and thus helping in enhancing the plasticity of the visual cortex, which could be either monoocular or dicoptic. Now, complications and resurgery are a part and parcel of any surgery. If you've left the child aphakic, probably because a completely subluxated lens, or probably because the eye was too small, as Ayush mentioned, less than 17 mm for the axial length or less than 9 mm for the corneal diameter, then you may plan a secondary IOL when the eye has grown significantly enough and when these prerequisites for secondary IOL have been matched, which include sight, specular, and sulcus. 3 S that you need to remember. You need to see that the best corrected visual acuity is significantly better than the uncorrected visual acuity. You can use either, if the child is old, you can see the sulcus on the slit lamp biomicroscopy, or if the child is young, you can do an EUA and you can use an ultrasonic biomicroscope to see for the sulcus. And specular in older children, decent specular should be there for a second surgery to be done. Anterior chamber assessment, as always, needs to be done. The ciliary sulcus, if present, then a 3-piece IOL in sulcus is the most practical and the most physiological thing. And in older children, when you're planning for a secondary IOL, an optic capture definitely should be done because it enhances the stability of the IOL. In this case, you can see that the UBM is showing a good sulcus, and when we have put a dilating drops inside the eye, so you can see the sulcus all around when you put dilating drops, and after which you can put a multi-piece 3-piece IOL in this sulcus. So if there is no sulcus, then there are 3 options that you have: an anterior chamber IOL, an iris claw IOL, and a scleral fixated IOL. In cases when the sclera is weak, like in Marfan's, in Beale's, or in ophthalmic eyes, there it is preferable to avoid a scleral fixated lens. And in cases where the iris is slightly irregular and iris claw may not be an option, then ACIOL is a good option, but there has to be no pass and the AC has to be a deep with a significantly decent specular count. The corneal diameter sizing is an issue with ACIOL because it only comes in 2 specific sizes. So corneal diameter has to be between 10 to 12.5 millimeters. PI is mandatory to prevent glaucoma. Iris claw IOLs can be either anterior fixated or retrofixated. You can see here on the image on the left, there is an anterior fixated IOL, and the image on the right, we have inserted the IOL inside with a 5 mm incision, used a dialer to make it into the position, then used a lens holding forceps and enclawed one claw, and then clawed second one with enclavation forceps, and then sutured it. We are slightly skeptical about using scleral fixated IOLs because in patients where the aphakia is left are usually the patients where there is a high risk of scleral weakness, scleral abnormalities that may be present, and thus haptic extrusion and problems may arise. Thus, we only prefer SFIOLs in children more than 6 to 8 years of age. Complications are a part of the surgery, which may arise from 27 to 58%, the most common being the visual axis opacification. It may range from something benign as a peripheral axis opacification to something as malignant as phthisis bulbi. VO can especially be there when inadequate anterior vitrectomy has been done, where the retained hyaloid face may act as a scaffold for the proliferation of the lens epithelial cells, which can either be managed by a trial of cycloplegics, where you can give hometropine or atropine for a period of 3 to 4 weeks and see if there is any response to reduce inflammation and reduce the type of VO that is there. If there is no response, which is usual in the case of combined fibrous plus proliferative cases, then you can do a bimanual vitrectomy either via an anterior approach or via pars plana approach and remove it. Refractive shift is an expected change. How much ever you try to correctly target the IOL power and use all the AI-based formulas, regression, theoretical, you can never predict the axial length growth in children. They may be either because of the inherent growth of the eye or because of the incompliance of the parents. So a child operated 6 months, left 20% under correction, may come to you at 10 years of age with -15. what you can do is an IOL exchange in those cases. A preoperative squint may become better with an improving visual acuity, but a post-operative squint may develop if the child is not compliant to glasses or occlusion, leading to a fixation preference of the better eye. Other complications include glaucoma, which is again rare, but is seen specifically in eyes that are small with overcrowding, in complicated surgeries, and in aphakia more than pseudophakia. Retinal detachment is very, very rare, but it has to be mentioned as a part of the complication. It has any sudden decrease in visual acuity on post-op needs to be seen on indirect ophthalmoscopy. Risk factors include high myopes, an incomplete vitrectomy, excessive manipulation, or resurgeries. The most important cornerstone of the entire process of pediatric surgery is explaining the prognosis and counseling the parents about the potential of vision and their involvement in helping the child achieve the visual potential. So to conclude, follow-up, you remember 2 Ps to check the progress of the child by seeing the visual acuity, by seeing the change in the biometry, and the power. You have to prescribe power at every 6 months. Glasses, you remember 2 Cs. It is critical that the child wears glasses all the time and that it should be correct power and correct fitting. Occlusion, you remember 2 Ts. It has to be total occlusion, part-time or incomplete occlusion. Incomplete occlusion of the eye is not going to help, and timing has to be seen. If it's 4 hours, 6 hours, part-time, 2 hours, that has to be seen. Complications, 2 As, always anticipate complications, so you are absolutely ready for it to act on it when they arise. Counseling, 2 E's. It is essential that you counsel the parents and that you have empathy towards their children. Thank you.
Yep. Thank you, Aishwarya. So she covered up all the way. Diksha, I need your finger thumb on this one. Okay, so we can have one question in the meantime, but what she's talked about, that just clearing the media is one of the things. To keep it clear is what you have to do, and keep giving glasses and keep focusing the light. Let me count the number of people sitting here. Himanshu is 1 to 50, 51 and 52. 52 kule. Your ARC guy is here. So your 52nd number, 52 kule. Okay, so. Okay, now, so we'll discuss everything later. Now, how do you decide what lens power you want to put in the eye? I mean, okay. So one is the target refraction, the other is the myopic shift, right? So these are the 2 things. If you know about these ones, I think you'll sail through. So is the small adult infant eye as just a small adult eye? The answer is no, because if you see the cornea, it's as steep as about 52 at the birth, and the axial length is about 17. And over a period, the cornea keeps going flatter and the axial length is increasing. So this is what is called emetropiization. So all the old textbooks which you say that all the pediatric age group kids are hyperopic, should be burnt and thrown out of the window, because they are not. So I'll be just showing you the study from Gordon et al. In which they have talked about how they did the study, and we'll just go into details on that. So axial length changes, keratometry changes. Infant sclera is half as thick as the adults, so please do not do any SFIOLs in these ones. Until unless the kid is about 7, 8, 9, 10 years. And even if it's 10 years old and a Marfan syndrome or a Beal syndrome in which the sclera is thinned out, please don't do a scleral fixated in these ones. Iris is the only option, these ones. And you can put a retro fixated iris, or you can do an anterior foreclaws, which we recently started doing. So obviously the eye grows, but how much can anybody predict? So let's find out. Why should we go into the undercorrection? Why can't we give whatever the emetropic power is there and then, and let's get over with it and keep giving the glasses? So what we realized that if you keep doing that, you might have the myopia, which might be very, very high. Initially, it's less amblyopigenic, very good, but eventually you might have to change the lens in all patients because all these eyes will grow. I'm talking about the eyes which are 1 month old, 3 months, 6 months, till 2 years. The earlier good old books used to say don't put any lenses in less than 2 years of age. Even the IATS studies say so. But since we started doing these surgeries for the last about 15, 20 years, now we realize that this is the way to go because most of the phakic lenses will not be effective. And parents who are from the poor strata, they might pick up one pair of glass, and once it breaks, they might buy one more. and after that, they'll stop using the glasses. So as much correction you do with the IOLs, I think you should do it if you can put it safely into the eyes. Okay. So the advantage is that if you keep them emmetropic, you will have less amblyopia during that period, maybe a month or 6 months. But eventually, this will start growing up. But how much it's going to grow, let's see. Look at that. So basically, a moving target versus a still target. In adult cataract, everything is grown up. Excellent keratometry you get in Eureka, you got a power. You might still have an error of a plus 0.5, plus minus. Okay. In the pediatric, it doesn't work that way because the axial length is changing, your keratometry is changing. So whatever formula you use, everything's going to fall flat. So let's see how we do. Now, this was the study I was talking about. So kids, when they're born, they have a normal refractive error about 0.4, plus 0.4 to a minus 0.5. And that's about it. They're not plus 5, plus 6, plus 7. If they were like that, why wouldn't every kid born be wearing a glasses? Because they can see for near. As long as they can see for near, that's good enough to develop the retinal function and everything at the back, at the optic tract. So they're not hyperopic. So how did we come to this? And if I ask you a question, what is the A constant of your own crystalline lens? Can anybody tell me? Because you have your keratometry, you have your axial length. So all these IOL companies, they give you A constant for the lens. If you try to back calculate, your keratometry, your A constant will be about 116.4, which is what was seen in the case with Gordon's. So they say that in the first phase, it's an early phase, which is fast growth for the axial length, and then it goes slow, and then it almost stabilizes, right? So let's see what happens. So if you look at this data, I have a pointer here. I'll use this one. So axial length at the age of 30 to 35 weeks. So what these people did, they went to the nursery where the kids were born, and they took the consent from the parents, and they put a drop of cyclopentolate in each of these kids and did the axial length keratometry, refraction, all the examinations, right? But they did a consented, otherwise it would have been not the correct thing to do. So they realized the axial length at the age of 35 weeks is 15.1 plus minus 0.09, which is a very small eye. And you see the keratometry, it's about 53.5, so it's very steep. Now these are actual patients in which they did it. And by the time they realized when the kid becomes about 3 years old, it's 23.5 at the age of 10 to 15 years and goes to 43.5 as a keratometry. So one is increasing, the other is going down. But if you see the net, the refractive error stays more or less the same. So you see the refractive error starting from the beginning. So it could be -1, plus 0.3, all the way to down. So this, except one diopter, there's not much of a change in these ones. Is that clear? So it's the emmetropization. The eye is increasing in axial length and keratometry going flat, with the lens in the center and the cornea also a refractive body. So what happens if you remove the lens in these patients? So now all the equation has been thrown out now because the lens is not there, so focus is not there, there's a blur. So the peripheral blur can cause havoc. All these things can cause growth in the eye, or it can cause retardation of the eye. So if you see all the studies, they say there's an increase in the axial length in these patients when the patients don't wear glasses. If they are undercorrected and don't wear glasses, the eye is going to go much more than proportion than what they expect in a normal population. So, okay. This gentleman, McClatchy, made a formula to have IOL power calculation, that you take the age and the refractive error and you press a button, you get the power. It fell flat because it doesn't work. It doesn't work in pediatric age group. You can't predict which eye is going to grow how much. So let's see what is the growth now. If you look at the growth, I think the best paper there is this one in which Wilson et al. They found out that in the first 6 months, every month there's a growth of 0.62 millimeter. So that means 0.6 into 6 becomes 3.6. So from birth till 6 months, the eye has grown by 6 millimeters, which if you take all the SRK and all these formulas into 2.5, it goes a huge power. So there is a definitely shift. The younger the patient, the more undercorrection you have to do. I'll tell you what formula we follow. And after 6 months to 18 months, it's moderate, about 0.19 per month. And after 1.5 to 2 years, it's again changing, but it's very gradual. So there's one study in which they used, at the age of 6 years onwards, they used normal, no undercorrection, and they found it doesn't make any difference if you do undercorrection or not. All right. So what are the other factors? What age have you operated this child first? Whether you put in an IOL or is it a aphakic patient? Because aphakic patient, even if they wear glasses, the image quality in the periphery is not going to be the same because all the prismatic effect from the pincushion from the aphakic lenses. So that's not a way to go. So they might grow faster and much more. there was a study in which they used rigid versus foldable lenses, but rigid everybody stopped using, so I think there's no point in discussing that. Unilateral versus bilateral is a big issue because unilateral surgeries you do at an early age, and if you don't give them glasses, not occlusion treatment, they might grow much more than the other eye and may become longer than the other eye. So rehabilitation, which Aishwarya said, is very important. Intraocular pressure has to be measured. The eyes in which there was intraocular pressure high, I did a study with my glaucoma colleague, Dr. Vinay Gupta, in which we picked up these patients with the open angle glaucoma in the children. We realized that it was a problem in the first few patients. We didn't know what power we were using. There was all going haywire. We had to exchange the lenses. Gradually, we realized that the bigger the eye, the more undercorrection you need to do. And if your pressure can't be controlled, even that much is not adequate. It will keep changing with the pressure going up and down. So it's a very, very crazy thing to do. And the most thing, like a genetics, if the patient is a Caucasian, Indian, Asian, I think it'll make a difference. So whatever is happening in your population is your duty to see these patients for follow-up. And every time they come, you do excellent keratometry and refraction and keep holding to your data. In 10 years, you know what is happening in your patient because there's no shortcut to that. All right, so these are the studies which talk about what is the growth like. I think I'll skip from that. And we have about 15 minutes to go. Okay, so there was a questionnaire which was sent by Ed Wilson to the adult cataract surgeons who was doing pediatric surgeries and to the group of APOS, for the pediatric ophthalmology services group. And they found out that all the people from the APOS, that APOS, which is the pediatric ophthalmologist group, they were doing, at 6 months, they're doing high hypermetropia checkup, residual. So you're in high hyperopia, moderate hyperopia, and low hyperopia. So depending on the age, the higher the age, the low hyperopia is what you anticipate in these patients. Okay, so lenses I'll skip. Unilateral is always more associated with excessive elongation if you don't follow this patient properly. So this is what I was talking earlier. All these gentlemen in the past, Dahan and Prost, they used to do lots of undercorrection, more undercorrection, which in our eyes we realize that it doesn't help. So their eye growth is faster, ours is not growing that much. So what we come to, and this is another formula by NBRD in which it's very simple. Age of the patient plus refraction you want should be 7. It's a very tricky one, but by and large, if you're excellent in keratometry, are finding in the middle of the Gaussian curve, plus minus 2 standard deviation, you can get away with that. So this is a very good formula. Rather than putting too many complications to it, you can follow this one. Other one, we did a study at the RP Center in which we took 4-5 groups, less than 6 months of age, 6 to 12, 12 to 2 years, 2 years to 5 years, and 5 years and above. So all these groups has been now followed by at least for a year and a half now. And we've seen that the 6 months has become 2 years. So we got a good follow-up of these patients with excellent keratometry and whatever error we got. So what we found out excellence was, mean excellence is there and then the keratometry on the side. And this is the power which we put. In these patients, less than 6 months, we put about 25.5, which was 20% undercorrection. 6 to 12 was 12.5. And then from this, we came out, and we use the SRK2 formula. From this, we derived one formula which says that if it's more than 5 years, there's no need to undercorrect. Whatever power you're getting, if it's say 22.23, you can take 0.25 less, whichever, because the lens is not available in a 0.25 jump. They are on 0.5 jumps only. So you can just go to the first. We got 15 minutes more discussion. So you can stop that. Yeah, thank you. So if it's 5 years, do 2%, and at 2 years, do 5%. Remember 2.5 plus 7. So it works well. Then less than 2 years, if it's 1 to 10 years, 10%, 1 to 2 years, 10% undercorrection works wonderfully well in most of the patients. 95% of patients will fall in that group and they're doing good. The problem 6 months to 1 year is a little tighter zone, but we realize that 15% is good. The moment you touch 3 to 6 months, you have to do 20%. And that is still okay because we're getting higher hyperopia. We aim at about plus 8 to plus 10 in the glasses. That's good enough for them. But if it's less than 3 months, especially a unilateral cataract, you still have to put IOL because if your patient is not on contact lenses and unilateral FAK glasses, they're not going to help you anyway. So this is very high. We are looking at these patients right now, and we have explanted about, exchanged about 6, 7, 8 patients by now over the last 20, 25 years. And those are the one in which the surgery was done earlier, and they've gone to about minus 12 is what they got, and we exchanged the lenses. And amongst them, I think one patient, again, eye grew, and we had to take the lens out again for -7. So that means from the birth till the age, he was 17, 18, 2 exchanges, and both were about a -11 and -8, so -19. So that's a huge shift in that one. So this is the formula which we at our RP center we're using in the center. So if you talk about the newer gimmicks and all, which you talk about adults and ELP, in pediatric you can't decide the ELP of the patient. How do you know where the lens is going to park? If your vitrectomy is not a standard vitrectomy, if you've done more vitrectomy, your lens will go a little posterior. If you've done less vitrectomy, it will come a little anterior. So you can't depend on the ELP as much in these ones. So that means you're not very clear. You have a gray zone, so you have to work out in the gray zone. If your post-op error is a ±2 diopter on the first day, I think you've done a good job. But still, I'll be more happy if it's a +2 rather than a -2. So we aim for the hyperopia undercorrection. That's what is the name of the game. Because -2, if you have, it's going to go up to -6, 7, 8. Or maybe if your occlusion is not given and the glass is not used, he might go to -17, -18. And then you can't control with the refractive corrections also. Even the LASIK won't work in that one. So you have to work up these patients properly. You have to insist that they follow whatever Aishwarya told them to do diligently. Okay. So I think we'll skip single piece is what you should do. Now, there's another thing. If you are putting a poor quality lens in the patient and you have a glistening which is happening in the adult, you do the surgery at the age of 50, the glistening develops by 10 years, 60 years, that's fine. But the child who's going to live for the next 80, 90 years, please be very diligent in picking up the lenses. It's best not to put a poor quality lens in the patient. It's better to leave them vacant rather than putting a poor quality lens in these ones. So we can't afford to have any glistening. So this was one study in which they found out the 2 eyes in which pediatric lens they had to exchange because of the glistening. All right, so there's a bag in the lens technique by Mary Thesigan, but that lens has its own problems because the lens will be centered on the rexes which you create. So the ankle kappa is not possible in that one. Whereas in a lens in the bag, you make a rexis and you put the lens, even if your rexis is eccentric, your lens is going to go into the bag and open up, right? It's going to follow the bag. Whereas if you have shifted both the rexis off center and you implanted the lens stuck to that, it's never going to come into the center. All right, Dr. Leela? Because if your rexis are not in the center, lens is not going to stay in the center as good as that. Okay, so now let's see what this gentleman has learned. So this is what you need to do. You have to shoot the target. You see there's a target which is moving, the eye is growing, and he misses the bird, right? So maybe after attending this symposia, and you've taken the exit length into consideration, you've taken the ethnicity of the patient, intraocular pressure, the lens where you put the lens, and then you try to shoot. If you notice here, you'll shoot the thing. Yeah, but that's not a one bullet which is shooting. So there are multiple bullets. That means there's so many options you have to shoot the target. So even if you're missing that, that means you're quite off the target. So even if you have a target which is moving and you have a multiple bullets, so you can have a plus-minus diopter. So I said you can have a +2, +3, +4. That's still okay because they'll start growing into it, and that's what you get it. So I think we'll close it, and we are open to questions now. We got 15 minutes clear, and thank you very much for being such a nice audience. And we got Pachpan Kule now. We got 4 more people. Okay, the questions, please. Good.
Good evening, sir.
Can you tell who you are first, from where you are, and then ask the question?
I'm Dr. Sujit. I'm practicing in Hyderabad.
Okay, great.
Does the same normogram apply for cases of traumatic cataract, say a 3 or 4-year-old with a unilateral trauma?
Yeah.
So do we need to do bang-on correction or under correction?
Perfect. I think that's a great question. Okay, so traumatic is another ballgame altogether. So the eyes which are traumatic will not grow as much as the other eyes. So if there's a change in the, what do you call the equilibrium inside. So you can go under correction, but not that. Whenever you have a unilateral, always do less under correction, right? So if you do less under correction, this one, so if you're getting, for the same age, if you're doing, say, under correction by 3 diopters, here you go by 1 diopter, 1.5 diopters. So go half of that. That'll be good. And in the traumatic, if you have a problem, you can because anterior capsule, posterior capsule might not be intact. So you can put a 3-piece in these patients if both the capsules are stuck together, make an opening in the center and do a capture. In a bigger kid, you can do a capture because the lens doesn't have to be changed later on. But in the younger kids, don't do a capture. with the 3-piece because you might have to remove this lens. So always keep that option open. Yeah.
And recently there is increase in myopic shift in children. We are seeing a lot.
Yeah. Okay.
Because of the gadget usage and all.
Yeah.
So does this normogram say after 5 years, does it still hold?
Yeah, this normogram we've been following for last quite some time now, I think. And before we published this work, I was using that for around 20 years now. For whenever we try doing more undercorrection, like Prost and so we always had even after the age of 16 years, they still were hyperopic. So that's the problem, because hyperopic vision is not as taken as well as a myopic vision. Yeah. So you do it in your patient, and please come out and we'll discuss.
Sure, sir.
One question.
Sure.
In place of your PCCC, then putting the IOL, can we go with a vitrector behind the IOL, then do the with the vitrectomy? Can you take up the posterior capsule and do the vitrectomy both in one setting?
Yeah, that can be done, but it would be better to do it from a pars plana route, or even from the anterior route also we can go behind and do a vitrectomy under the IOL. But it's usually better if we do a PCCC with an IOL if everything is clean. That usually gives a better and more well-centered IOL.
Yeah, when you do a vitrectomy after putting the lens, you never you don't know how you've done all around 360, right? But whereas what they showed you was you do from one side and change the hand and do from the other side and let it fall back all the side equally. So your ELP, effective lens position, will be much better here, and chances of VO are less. So if you cut from the back, you have to do a bigger vitrectomy, so you might not be equal on both the sides. So you might have a cataract coming from one side. And it's not difficult. I don't know why you people are scared. PCC is much easier than ACCC. ACCC is the one which is like a dome up, so it runs off. PCC hardly ever runs unless you overfill the bag and you push the bag so much down that it's a reverse top of the hill phenomena. So it's like a dome up versus dome down, and you give a nick, it opens posteriorly, the nick, and then you have a problem controlling it. Okay, so what she showed you was that you let the chamber go flat, let the posterior capsule actually go with the helon behind it, inject it, and make the posterior dome like anterior dome. So make it an anterior capsule curvature and do it. And she showed very well on the video.
Thank you.
Ma'am.
Just a question to Dr. Aishwarya.
Sure.
I don't know, we do some dioptic treatment for routine amblyopia, or more in an isometropic actually. How far it's effective, because most of the unilateral cataracts are refractory, and how soon, and do you have experience in dioptic treatment?
Ma'am, we've started studies in RPC for the same, but dioptic as a standalone treatment has been not effective.
Not standalone.
As an adjunct to occlusion therapy, yes, it has had more advantage. It has moved from a category of a severe amblyopia to a moderate amblyopia in cases which was not refractory to just occlusion therapy. Dioptic treatment we have followed for 6 months and seen a change in the amount of visual acuity that was there, and especially fixation in younger children. Also.
Okay, thank you.
Thank you, ma'am.
Is there a question? Lovely, come.
Good afternoon, sir. I am a junior resident, third in Rio, Allahabad. I'm actually doing a thesis on this, and I made a basis of your study in RP Center that you did on the pediatric age group. So I just wanted to know that before you concluded about the study in how much undercorrection amount of lenses that you're putting, I just wanted to know before the study that you had done, what was the undercorrection that you were taking for the pediatric age group, after, in which you were putting the IOLs? Like how much undercorrection were you doing for age groups? Like after 1 year, were you doing 10% undercorrection?
Yeah. So yeah, okay. So we were going 10 to 12% there. Okay. At one year, 12 months means 12% what we're doing. Yeah. Now we even reduced that by 2% further now. So it was not that tightly moderated. Now, in fact, it's become much tighter.
Okay.
So initially we had little dingers, but we had about a +3, +4. So you go in the term of hyperopia. So if you can have high hyperopia for 6 months group, and from 1 year till 2 years, if you can have a moderate hyperopia, and after that, if you can have a mild hyperopia, I think you will be good. So you can use the anybody's principle 7. We used to use that 7 formula. It worked pretty well, actually.
Okay. Thank you so much. Thank you, sir.
Welcome. And all the best for the thesis.
Thank you,
If you have any queries, these guys are there. Otherwise, you can mail me. We can help you out. Perfect. Is there a question or he's going out? No, he's going for the next session. I just asked one question to Ayush. Ayush, how important is the examination and anesthesia according to you?
So examination and anesthesia, very comprehensive evaluation, because we can't really afford putting the child under general anesthesia every time. So nothing should be missed, especially like in cases of traumatic cataracts. We can say if the child is under anesthesia, we should do as much as possible. For example, gonioscopy, intraoperative gonioscopy should be done for children with traumatic cataracts to look for any angle recession. Then, as I mentioned in my slides, even intraocular pressure assessment preoperatively is very essential, since if there is already preoperatively there are high pressures that has to be managed for optimal outcomes. So like I said, we cannot afford to give GA every time, so we have to be very meticulous not to miss any particular investigation during our time under anesthesia.
Yeah, and I would like to add on that once you take a congenital cataract, traumatic is a different ballgame altogether. So if you have a congenital cataract, it's a bilateral, normally the eye is going to be normal, healthy eye, good size. Unilateral cataracts, always the pathology is in the eye. So if you're doing a UA for the unilateral eye, please go into all the details. You should have an indirect ready, you should have a UVM ready, you should have an ultrasound ready in case you want to do it again on the table. You have to do the keratometry, everything again, and be ready with the camera. And if you have, I think, how many of you have UVM with you? Okay. Oh, that's not bad. Because last time when I asked, nobody had UVM for the pediatric. So this is dedicated. We have one dedicated to pediatric. And the second thing which on the table in the cataract surgery you can do is, you can put in a ILU in the eye and put a wide angle on the top. So we have recorded the pictures of the fundus of these babies who are from 1 month till 10 years of age, and nobody had seen their retinas before. This kid is born with a ROP, and nobody could give an injection, and it developed, and there was a cataract. So we cleared the cataract. At the same time, we did with the ILU. So ILU doesn't have to go into the vitreous all the way. Once you take the cortex out, your posterior capsule is clear. You can just go over there, and the chandelier effect, you can actually take the images very well. So we keep the images of all. So that we've been doing for the last, I think, 3-4 years now. So we have gone where nobody had gone earlier. So if you have a cupping which was not there, and the patient comes for follow-up and you pick up a cupping, that means something has gone wrong in this patient in between. So these are the patients. So I think you can't take this patient lightly, because each patient is a potential citizen who's going to live for next 80, 90 years. So nothing which is short here. So whatever you do, please do over investigations on the table once the patient's under, rather than leaving something away. And whenever you see one eye in a traumatic or any other patient, please always assess the other eye, because there could be a refractive error there could be a problem in the retina which is not seen, because one eye is traumatic is fine, but what about the other eye? So many times we get the patient with one eye cataract, the other eye vision is also poor because parents never got the glasses. So please, for God's sake, do refraction for the normal eye also, and look into the retina, especially if the child is on the anesthesia EUA, please dilate both eyes and see. Okay? And if there are no more questions, I think I'll thank the panel. And these kids have done a wonderful job and made me proud. So thank you very much, everybody, for coming. And bye. Enjoy Kolkata.